I have the immense pleasure to introduce my current PGY6 Chief Resident in Neuropsychiatry, Dr. Pooja Modi. I'll give you a little overview of her path here to UMass and to neuropsychiatry. Dr. Modi studied her undergraduate degree and a Bachelor of Science at University of Michigan, Ann Arbor. And then she completed medical school at Rutgers Robert Wood Johnson Medical School in New Jersey. And she came to us in July of 2018. And I lose track over 6 years, and I like to kind of think about what things were like in July of 2018. I had been in the training office for 1 year, and we were just blissfully naive to the idea of COVID and endless Zoom meetings and quarantines and all of that at that time. So think about that, and then imagine her 6-year journey through training where all of these things occurred while she was here. So while Pooja has been here, she's done an incredible job between both programs, bridging the gap. I'll just mention a few of the incredible presentations that she's done so far that she's been with us. You know, her interests are very broad, interest in, healthcare disparities in minority populations, autoimmunity, personality disorders, psychosis and Parkinson's disease, neuropsychiatric sequelae of COVID-19, because none of us could ignore that. And that is really still an issue now. And one might think that these are really broad topics, but for a neuropsychiatry resident, this is what we do. And in addition, sort of focusing in on neurorehabilitation, traumatic brain injury, and topics such as that. Today, she will be presenting on neurorehabilitation and how to essentially, I'm very excited to hear about this, but I'm imagining how to bridge the gap between the neurologic side of those illnesses and the psychiatric side. So without further ado, I will invite Dr. Modi up.
Hi, everyone. Like Dr. DeGresh mentioned, I'm the 6th year combined neurology and psychiatry resident here. And thank you for that amazing introduction. It's been a really long journey to get to the point where, I've actually found one of my stronger interests in neurorehabilitation. And so today I'm going to be focusing on some of the things that I think have been kind of recurring themes for me over the last 6 months. This year, I actually got the chance to incorporate more of those neuro rehab exposures into my schedule. And so I really wanted to kind of focus on the patients and some of the concerns that they bring to me. And one of them tends to be not necessarily medication management of, the sequelae of the traumatic brain injuries or even non-traumatic brain injuries that, occur to them, but more so the questions that sometimes, give me a little bit of a panic attack because I don't necessarily have an answer to those questions. Questions like, what's wrong with my brain? Or how do I fix it? So this is kind of one approach, the psychotherapeutic approach that I'm hoping to talk about today. I don't have any actual or potential conflicts of interest in relation to this presentation, and I just want to preface this presentation by stating that I am definitely not trained as a psychologist or a neuropsychologist, but I definitely admire what they do. A lot of the research that I'll be talking about comes from the clinical psychology and neuropsychology worlds. So I just want to say that even though a lot of the information is coming from there, I'm hoping to utilize that more into my clinical practice as opposed to offering the same expertise and same services that they do. So the main objectives of this presentation are to describe what the role of psychotherapy is, not only during rehabilitation in the post-acute and subacute stages, but also to talk about how we should continue that after they leave the rehab setting. And it's to recognize how psychotherapy may be different in the rehab setting, if it's done at all, versus how it's different in the clinical settings that we often see our patients in later down the line from the time of injury. And most importantly, it's kind of a self-serving presentation because what I really want to gain from it is a few of the techniques that are being used in rehab in terms of how psychotherapy is incorporated and use that in the clinical setting when I'm seeing those patients, not only for med management, but to provide some support while they're going through their recovery. And not only in the psychiatric practice, which is important to a lot of us here, but also in my neurological practice too. So I really, really love this quote. I've been hearing it a lot for the last 6 months. Every interaction is rehab. And we kind of change it according to like what we're doing, but the theme behind this quote is the same, is that regardless of where you see this type of patient with either a traumatic or non-traumatic brain injury, every encounter that we have for them is a way for us to kind of change the course of recovery, maybe in a positive way. And so I'm hoping that that by adding some psychotherapeutic techniques to my interactions with them, that I'm actually able to create a better therapeutic alliance with them. So one of the things that I've seen a lot, like, for example, those patients that come in with the question, what's wrong with my brain? How do I fix it? One of the things I've realized is that there isn't one simple answer. I just recently, last week, had a patient come to the VA cognitive clinic that I work at across the street with Dr. Barrett, who's the chair of neurology. And I saw a patient for what I thought was going to be for the memory changes and the cognitive changes, as well as some of the mood changes that they had been experiencing. So I was ready to be like, this is the list of medications that we could use. This is going to take this much time to improve. And I was kind of taken aback by really what they were there for, what they came to me for. And this is someone who had sustained a very large MCA territory stroke on the left side. This is someone who had made like remarkable motor recovery since May of 2023 when the stroke actually happened. And, you know, not necessarily his question, but his wife's question was, how does he get back to himself? How does he find meaning in life now that he's different after the brain injury? This is someone who, prior to the brain injury, even though he was retired, was doing carpentry at the age of 77 and engaging in projects that, you know, a lot of people at that age probably wouldn't, because he was that healthy and able to do that. So it kind of struck me as, why aren't we focusing on this question more when we're seeing our patients rather than jumping right to the medication management? Could we be doing more in this aspect? And this is exactly what Dr. Kurt Goldstein back in the early 1900s was a proponent of. He really wanted to, with his research, show that there can be a more holistic approach to working with these types of patients who acquire these pretty serious brain injuries and then don't necessarily know how to assimilate back into the community. And so in the early 1900s, Dr. Kurt Goldstein, who was a neurologist and trained under Dr. Karl Wernicke, very briefly, he had these dreams of creating the first outpatient rehab program that not only focused on sort of the motor recovery that comes with some of these injuries or the cognitive changes that come, but also the psychosocial changes that happen for these patients. And so what he did, and this is one of the first research studies of its type that I could find, is that when soldiers were coming back from World War I, what they ended up doing, or what Dr. Goldstein ended up doing, is finding the patients who had gunshot wounds to the head, and he recruited them to be followed for 10 years. And he would see what sort of the outcomes are for these patients. And the whole goal was to see how we can change that process of recovery at that time, so that we are focusing more on how they can be integrated back into the community, whether that means, for example, things like finding employment again, which is really tough if you think about some of the sequelae of traumatic brain injury, like brain fog or cognitive slowing, or the really severe mood changes that happen, for example, agitation or irritability, anger management issues. He is definitely someone I admire because he started this thought process of at a time when, it really wasn't thought that people could recover from brain injury. He was one of the big advocates for saying that they can, because there are ways that the brain's compensating. And even though he didn't use the term networks, he actually was the one who kind of triggered that process of thinking about the fact that different regions of the brain are connected. And when one breaks down, there might be other regions that might be compensating, or on the other hand, might also become dysregulated. So he was one of the first people to to get us thinking about the modern concept of networks. So definitely admire him. And under him, later on, decades later on, Dr. Yehuda Ben Yishai, who is a clinical psychologist or trained as a clinical psychologist. Dr. Ben Yishai kind of adopted some of his ways that he was interacting with patients so that he could offer more holistic therapies. And Dr. Ben Yishai met Dr. Leonard Dillard, who is also a clinical psychologist at NYU at the Rusk Institute of Rehabilitation. And together, they actually developed one of, I believe it was the first program of its kind that not only looked at neuropsychological or cognitive rehabilitation and motor rehabilitation, but also looked at how psychotherapy can be incorporated into neurorehabilitation for patients who have traumatic brain injury specifically. Dr. Leonard Dillard was also trained as a clinical psychologist. And so both of their experiences together ended up not only creating this rehab program at the Rusk Institute, but they also developed workshops for people about a decade later so that they can be trained to see more of the holistic approach and how it might benefit our patients. So talking about holistic cognitive retraining is a pretty broad topic, something that I'm not going to be able to accomplish in this one talk. But I did want to kind of focus a lot on what they meant by a holistic approach, because that's kind of a vague term. So what they did was they actually trained patients to engage in their own therapy. One of the first things that they came up with was this idea or model of a therapeutic milieu. And a lot of us here have probably heard of this already because it comes up when we're working with patients with substance use disorders, but also when we're doing psychotherapy training here too. But theirs was specifically in the rehab setting, which is really hard to do. Think about someone who's hemiplegic, isn't able to talk, and to incorporate this on top of all of the things that they're already doing. What they wanted to do was try to find a way where it's a smooth transition, where it's integrated wholly from day one. So they came up with this model. And the first step, let me back up a little bit. These are hierarchy of stages. So you see where the figure of the head is, that's where you would start. That's the trainee or the patient with the traumatic brain injury. And the first step you want to take is to understand if the patient's actually able to engage. Patients with more moderate to severe types of brain injury may not be able to. So you definitely want to lay down a pathway of success as opposed to including everyone, including those who may not be able to engage. Maybe down the line they may be able to, but in that moment they may not. So first you want to see if they can engage. And if you can, if they can, then the next step would be to see if they're aware of what the impairments are or the sequelae that might be leading to worse impairment for them, worse function. And there's this concept called anosognosia, which is unawareness of deficit. And so they really focused on this because if they're not aware of the deficit, then it's probably not bothering them. So what exactly are we addressing? So once they figured out if the patient can engage in this kind of treatment, and if they're aware of the deficits, the next step is to understand where the frustration comes from. It's really easy to see, hey, I can't walk because I have hemiplegia. But what if it's deeper than that? What if it's, I used to do something I really love and I'm not going to be able to do that anymore? So if that's really, what's frustrating them, then we need to get to that point of understanding that. And so they wanted to directly ask patients this while they were in the rehab setting, which is something that's new. We don't often do that because our functional scales rely more on, for example, motor recovery. So the next step is mastery. So once you figure out that, yes, they're frustrated by this, impairment or, as they called it, restriction, then you try to find ways for them to compensate for them if they're able to. And so these compensatory mechanisms are things that they're going to do over and over with them. And this is actually where this concept of coaches come in. They actually train staff to help with specific restrictions. For example, if they had a communication issue, there would be a coach within the rehab setting that would help them with that and help them get over those frustrations so that they could actually master those compensatory mechanisms. So that's where why that stage is called mastery. And once they have that mastery, then the next step is for them to gain that control back that they've lost after having the traumatic brain injury. And so this is a really important step because it leads into our patients actually accepting that there will be restrictions, that there will be things that they may not be able to do. But on the other hand, there may be other things that they're doing better and can use to gain more meaning in their life and to be able to function the way that they want to. And that's kind of where that last stage, that stage that they're constantly working at, not only in the rehab setting, but after, of identity. So I think one of the things we don't always address because it can take time, and oftentimes we will have these like very brief 30 to 45-minute follow-ups, is who the person is in front of us. And so this can be a thing that takes years to figure out, not only for us as clinicians taking care of them, but also as the patients after they're trying to build their identity again after a traumatic brain injury. And so I think that, the whole point of these hierarchy of stages is to, as Dr. Goldstein would say, transform the individual's personality to enable him, her, them to bear those restrictions. That's the whole point. And for them to be able to function, like I mentioned before, the way that they want to, whether that means going back and getting a job or being more engaged with their family. These are the things that we would find out throughout these stages. And so Dr. George Prigatano, who's actually a clinical neuropsychologist, he went to those workshops that Dr. Ben-Yeshai and Dr. Diller set up at NYU, and he became inspired to include psychotherapy as part of the rehabilitation process for these patients. In fact, in the early 1990s, he had the seminal paper that came out that looked at the emerging role of psychotherapy. And he went one step further. He actually wanted to prove that the model that Dr. Ben-Yeshai and Dr. Diller set up at NYU worked. So he actually, created a prospective study to see if the psychosocial outcomes, for example, the likelihood of employment, actually improved, and they did. So he actually took it one step further to show that this is a holistic type of rehab program that could work for a lot of patients as long as they're able to engage. And he went another step further to say that, it's not only in the sort of chronic stages, but also in the post-acute as well as the subacute stages that this can be very beneficial. We should be starting early. In the 1990s, shortly after this paper came out, he also focused on that stage we talked about, which was called awareness. In fact, he had a lot of time that he dedicated to this concept of agnosia. And he wanted to see how this not only could affect someone's recovery in the positive way, but also how it could influence someone deteriorating as well. So looking at it from both sides of the spectrum. And one of the things that he also wanted to do was develop better screening tools as well. So he went another step further. And while the MoCA and MMSE are things that we're very familiar with, they don't often work in rehab settings. And so he actually created a new cognitive screening tool called the Barrow Neurological Institute Screen for Higher Cerebral Functions, also known as BNIS. And it was specifically catered to those patients that you see in the rehab setting because it actually accounts for the changes in affect as well as the changes in awareness that might come from the traumatic brain injury itself. So he did a lot of great work that we're still using today. I think with the research that Dr. Ben-Yishay, Dr. Diller, and Dr. Pigotano brought to the surface so that we could have more discussions about it is very important. Unfortunately, we don't actually have things like neuroimaging studies now to kind of support what they brought to light decades ago. However, we do have neuroimaging studies, DTI, fMRI studies that have come out in the last decade to show us that even though it hasn't been done specifically in the traumatic brain injury population, that we are using psychotherapy to address some of the sequelae of the traumatic brain or traumatic brain injury. For example, things like major depression, things like psychosis, anxiety for sure, OCD sometimes, and of course PTSD after traumatic brain injury. So one can extrapolate that, psychotherapy is also going to have not necessarily similar changes, but changes to improve the functional outcomes of these patients who have traumatic brain injury, because these are some of the things we see these patients for. But yeah, it was tough finding studies that looked at psychotherapy in the traumatic brain injury population, which is strange because we've been looking at it for the last 50 years. So I think given everything that I found, that I learned from, these wonderful people who've been doing this research for decades, I kind of wanted to focus the second half of this talk on what I've gained from their research and some of the principles that they, use in the rehab settings, and to kind of cater it to the patients that I see, both in the neurologic clinics that I see, as well as the psychiatric and neuropsychiatric clinics. So I think that this is a no-brainer. We've discussed this multiple times. We get trained about this, and that's that be open to the idea of this patient population being able to engage in psychotherapy. I think even now, sometimes I get calls from therapists about how they have this really bad traumatic brain injury. Are they really going to be able to engage? And the answer is simple. If they can drive to the clinic and they can have a conversation with me about their mood and how they're not functioning well, then yes, they can engage in psychotherapy. And so we should be offering it routinely for these patients, and not only for the patients, but their caregivers, whatever their support system is, if it's the entire family, which sometimes is not the case. Along the sort of journey of recovery, you do often find that they do tend to lose people who they were very close with, either because they've changed or there've been sequelae that prevent those relationships from flourishing further. And then it came to, well, there's a shortage of therapists. So what am I going to do? I can keep those patients in line to get a therapist in about 6 to 12 months, or I can kind of turn this around and try to use some of the techniques that I've learned from this research, from previous people who have studied this, and use it in the clinical setting to maybe start that process early. So one of the things before even starting that process in the clinical setting is to think about how severe their injury was, what their journey has been, and how severe it is now. Because you still want to, according to that model that Dr. Ben Yashay came up with, you still want to see how much they can engage. And if they want to engage, you can offer it, but they may not want to at this point, right? So you want to assess the severity of the injury that occurred and what the severity of the sequelae from the injury. And then also look back and see, were they able to engage when the injury first happened, and how is that now? And that kind of goes back to the question of awareness. Are they aware of their deficits? Even if they're not aware, are the family members noticing it? And is it causing some sort of friction at home or out in the community? So that's a really key piece of it too. Oftentimes, we're not only treating the patient, the person in front of us, but also all of their connections as well, which can be tough and overwhelming, but you definitely want to keep that in mind. And I think the first process to kind of undertake, once you've assessed, yes, that they can engage and that they are aware or the family's aware, is what came from Dr. Prigutano's research, which is that we really should be looking at the patient's subjective experience first. I had this patient in neuropsychiatry clinic here actually, who was completely overwhelmed, frustrated, anxious about the fact that he could not remember the events around the injury. And I believe he still might be in our clinic, but taken care of by another resident. But we would have actually that same conversation about how we're probably not going to figure out what happened because I can't seem to find it in the notes. He didn't have any family around him to kind of fill in those gaps. So then one of the things that we've really focused on is what's going on now and how we can use what he can remember to move forward. And not only use what he can remember, but really look at his strengths now as opposed to the weaknesses to be able to move forward from the incident. So really understanding that the patient's subjective experience is an important, very key piece to recovery. And this one I think is the hardest one for me, just because of the fact that we really want to tell our patients that they're going to get better. We really want to tell them that, yeah, you might actually be able to go back to school, but sometimes that's not very realistic. I have a patient in a neuropsych clinic who was going to college prior to a really, really bad traumatic brain injury, which didn't just affect his cognitive function, but affected him motor-wise too, and he continues to have pretty significant residual effects. And one of the first encounters I had was not only with him, but also his dad. And they came to me with the question of when can he go back to college, which is really tough to say, one, because I don't know where his recovery is going to go. But if we're being realistic about it, given that the injury was 3 years ago, and he's still having trouble remembering things, reading, and processing information, it might not be realistic to think that he's going to go back to potentially full-time college work, even in the short term. So we really just took one clinic visit to talk about that, as opposed to talking about medication changes. And I think that was really helpful because the next sessions, they were actually talking to me about how can he improve some of those cognitive changes that occurred after the traumatic brain injury. And now he's part of one of the state's traumatic brain injury programs, and he's thriving. So he's doing a lot better than when he first came to our clinic after the traumatic brain injury multiple years ago. So setting these realistic expectations can actually be beneficial both for you, but also for the patient and the family especially. And when you are talking about the different sequelae, restrictions that they may have, you really want to try not to overload the patient, their families, and yourself. because there could be multiple impairments, multiple concerns that they come in with, but it's really hard to say that I'm just going to focus on all of them all at the same time. And so what's really important next is to ask what goal they want to work on. And this is something that was part of that therapeutic milieu model that Dr. Ben Yashay came up with. You want to also make sure that while you're going through all of this, all of these techniques with the patient in the clinic, that they also have multiple supports out in the community. Their families are definitely very dedicated, and I admire them a lot for all of the things that they do. But it's also really important that the caregivers don't burn out, because they're a very important piece to the neuro recovery that happens years and years and years down the line. So one of the things that I found really useful is finding community resources that might actually be able to integrate psychotherapy more, but also other resources too. And that could be anything from, providing, nursing assistance, aides to help them out at home more. And so one of the other sides of the coin is that, yes, you provide all of these resources for them, but make sure you're also communicating with those community supports, because sometimes they're going to see things that you're not seeing within a brief, 30 to 40-minute visit. And so it's really important that sometimes if they're going to day program 4 times out of the 7 days of the week, that you actually talk to them. And it could be anyone. It could be staff. It could be the therapist that they have, the social worker, anyone who might be able to give you more feedback about how things are going. These are actually the community resources that I use or provide information about. And some of you may already know them, but I started getting more familiar with them over the last 6 months. And they're all actually found on the mass.gov website. Massachusetts tends to have better psychiatric programs overall, but I was actually really surprised at how comprehensive some of their traumatic brain injury programs are. And so one of the first ones, my go-to, is one from Massachusetts Rehabilitation Commission. They unfortunately have the restriction that it has to be a brain injury that was external, so traumatic, in other words, unfortunately. However, if they do qualify, then it's sort of like they have all the resources that they could potentially have. That could mean nurses, it could mean caregiver support, hotlines, but also individual and group psychotherapy, in addition to speech, occupational, and physical therapy, and cognitive. So once the patient does qualify and is accepted into the program, it actually creates this pathway for a lot of resources that they may need out in the community. Another association group that is private, but still not for profit, is the Brain Injury Association of Massachusetts, or BIAMA. And they also provide similar resources. It's actually very similar to how the Alzheimer's Association is for patients with cognitive impairment. And so they often have hotlines as well to help these patients out, as well as, for example, if there's any sort of financial assistance that they may need, they have resources for that too, in addition to some of the ones provided by MRC. And this is probably the hardest one, but something that we all come across when we're working with patients, where it takes a lot of time to get to, a place where they're really, maybe not necessarily happy, even content with their progress, is being aware of our own countertransference. I think that the reason why I'm so attracted to working with these patients is that each patient and their family require an individualized plan. You have to think of creative ways to work around how, their home setting might be, or what they're doing out in the community, to figure out ways to help them function better. And I think, it for me is exciting to think that there are options beyond medication for these patients. And so I find it very fruitful, but there are also patients in that same category where, if you're making steady gains or even moving steps backwards, it may actually be more frustrating for the patient and their families, as well as yourself. So being patient with the course of neurorecovery, with those steps backwards is a really key piece, and not to get frustrated yourself, because it does work. So I just wanted to leave everyone with this quote, because essentially it gives people an idea of why I did this presentation at all. It's by someone I was obsessed with in high school, Albert Camus. And it's funny that it's an existentialist that came up with this quote, but it is. I see many people die because they judge that life is not worth living. I see others paradoxically getting killed for the ideas or illusions that give them a reason for living. What is called a reason for living is also an excellent reason for dying. I therefore conclude that the meaning of life is the most urgent of questions. And I don't think it holds any truer than those patients that I see who've had a brain injury, traumatic or non-traumatic. So I think this is pretty much what I'm hoping to change my practice so that I'm focusing on this a little bit more. These are my references. And I want to thank everyone for getting me to this point, but I especially want to thank that couple that I saw last week, as well as people like them, because they constantly remind me that I need to be thinking about this. They constantly bring that issue to the forefront. So thank you.
Thanks very much for bringing the subject up. There's another subject I don't recall having been discussed at our grand rounds before. So, and congratulations on looking into this. So first of all, Kurt Goldstein is a perfect model for you. You introduced him as a neurologist, but of course he was a psychiatrist and a neurologist. He was chair of neurology at Tufts sometime just before, I think during World War II. And before him, the chair of neurology was Abe Meyerson, who was another neurologist psychiatrist, whose son Dave was our residency training director here in the 70s. So there's all sorts of connections. And he's the other things that he did are also relevant to what you're talking about. So the whole field of Gestalt psychology was founded in Germany by some students of Goldstein's because of his influence. And then the concept of self-actualization that you were kind of alluding to is his concept as well. And then Maslow, who I think was at Brandeis when Goldstein might have been at Tufts. I don't know if they're at the exact same time.
He was also at Brandeis.
Yeah, but I think Maslow also was greatly influenced and actually inserted one of Goldstein's ideas into his hierarchy. So here was a neuropsychiatrist who influenced the entire field of aphasia, alexiognosia, and then also influenced the field of psychotherapy. So that's perfect for you. So the question for you, though, is, I'm sure you've noticed in the last 6 years in the neuropsychiatry clinic that when we try to refer one of our patients for therapy, the answer is usually, I don't feel able to offer therapy to somebody who is either cognitively or neurologically compromised. I'm not trained to do that, whatever. And it's not just here, but in the community, we get the same answer. So the answer can't be that we all just have to do it ourselves. And it's not just brain injured people, because it's non-neurotypical people also who can't find therapy in the community. So I don't know if you ran across anyone who made good suggestions about this. I should also put a plug. Our own Dr. Clark, Erica Clark, has started a cognitive rehab program here and has groups available, I know, that you can contact her about. But I don't know if you ran across anyone who made suggestions as to how you can operationalize getting people any level of therapy once they have brain damage.
So I have like an N of 2. But I've had conversations with therapists where it's was probably like 10 minutes max, but kind of talking about what the therapist is typically able to offer, whether it's CBT, DBT, interpersonal, whatever. Just kind of giving them some sort of assurance that the patient can engage given what I'm seeing in front of them. That alone seemed to help a lot with the conversation, because I never got a call back saying, oh, they're still having issues connecting. Again, it was still an N of 2. But just having that conversation with the therapist was really helpful. And I also wanted to kind of chime in about Dr. Erica Clark's group as well. We had a conversation about this because I didn't know this, but Dr. Clark is not only a neuropsychologist, but she has a lot of like experience in therapy as well. So we were talking about how she often encounters therapists out in the community who feel like they don't have enough experience. And it's just about kind of reaffirming that they do to work with these patients. So
I noticed Erica's on Zoom.
Oh.
So would it be all right if Erica, if you want to unmute and say anything to rebut, you could do that if you want. Or not.
I have them on.
Okay. They're arranging for you to be able to unmute if you want.
Okay, I think I'm unmuted now, right?
You're here.
Okay, I just have a little bit of background noise, so I apologize. Yeah, no, I agree with all of everything that Dr. Modi and you have just said about psychotherapy and accessibility. I think that is a big challenge to try to find out, who is available and who can see people, but also how to educate. But I think it just means finding the right providers, but also building those network connections with those providers and providing some education that may be ongoing. When the person comes back 5-6 sessions later and says, oh, again, I can't do this because of my TBI, questioning whether or not that's true, and maybe being willing to have the ongoing discussions with the providers, not just a one-off at the beginning of treatment, I think is just one kind of tip I would add.
Thank you.
Thank you for that talk. I'm neither a neuropsychiatrist nor a neuropsychologist. So one of the questions I had as I was thinking about that model, the mastery, control, acceptance, and identity piece of it in particular, is that I would imagine one of the struggles for me would be, how do I know when they've kind of plateaued in terms of their recovery? Like, how do I know when to help instill more hope? How do I know when to shift gears towards a more radical acceptance model? And that would be one of the challenges, both from a countertransference side and a psychotherapy side. And I'm assuming that the answer is kind of keeping in close communication with neurology or whoever's following them from a TBI standpoint. But what advice would you give for those of us that are struggling with those kinds of issues?
I think with some of the literature actually that's come out over the last year on like the neurological ICU side, the neurology side, is more that we don't have a definitive answer with how recovery is going to go for someone. It depends on a lot of things. For example, how much exposure they have to rehab, what their supports are like. And so if they're coming to you in clinic and you're noticing that you're working on something specific with them and they have kind of plateaued, there's probably a lot of other things that you can also focus on that might actually help with that initial concern that they came in with. And so it's not necessarily diverting, but more like kind of complementing what you already did with starting potentially on another goal that they may have too. Because what we know right now is that recovery is a lifelong thing. It's never going to plateau because there's always something that is going to be there for us to work on with them, if that helps. And then specifically some of the neuro ICU papers that have come out, they've been more on neuroprognostication after someone's had either mild, moderate, or severe traumatic brain injury. But the thought process before was that we should be having these conversations about withdrawal to life-sustaining therapies early. And now the thought process is that people can still recover from a really bad brain injury 6 months down the line. So maybe we really shouldn't be neuroprognosticating until 6 months, maybe even 12 months, maybe even years down the line, because that recovery process is still happening. So if that helps also. Yep. Oh, Dr. Bees. He's got it. Yeah.
Thank you so much for that lovely talk. Quick question. Why would the Mass Rehab Commission only accept traumatic brain injury versus acquired?
I actually don't know the answer to that. It's not, so the way that they define it is external injury. And so of course that takes out a lot of some of like the brain injury patients that had a massive stroke or may have gotten a really bad tumor resected and have a lot of residual effects, unfortunately. I don't know why. I'm assuming their funding is coming from a specific group. So speeding tickets. Yes.
Statewide head injury. That's right. Get money. They get money. Fines people.
Okay. It makes sense then.
I also have a question. Thank you for that great talk. I had a really interesting situation when I was just a brand new baby therapist out in the community. I had a patient referred to me who the day after her 18th birthday was involved in a serious car accident and had a very, very traumatic brain injury. So legally she was an adult, which allowed us to access a lot of the resources that you put up there. But I was kind of reflecting on it and thinking, you know, if she had been a week earlier, are there any child or adolescent resources specific that you're aware of?
I know that there are people studying pediatric traumatic brain injury and that in other states like New York, there are comprehensive programs. Whether there's comprehensive programs like the ones we have for adults here, I'm not sure about that. So I'm sorry, I don't have the
No, that's
answer.
okay. Thank you so much.
But I don't know, maybe Dr. B knows. I see.
Okay, there's a comment online from Dr. Alan Brown. Those of you who are online can read it, but I'll read it here. He's commenting on Sisyphus's situation. He was punished by the gods by being consigned to roll a boulder up a hill that would roll back down as soon as he neared the top. Camus noted that Sisyphus has a choice. He can smile or not. How we live with our human condition, which is pretty Sisyphean in general, is a good question.
Thank you, Dr. Brown.
And I'm going to add a comment off of Brian's comment on, you know, how long rehab lasts for and how do we know when to kind of quit and how do we know when to instill hope. And I was thinking about what Dr. Modi was saying about the case that she saw, the young gentleman who was in college, had a terrific injury. She was talking about 3 years later, they were still asking about college, right? And in the literature, just like she's saying, in neurology, we used to say, you know, 1 month, 3 months, 6 months, 12 months, and then you're kind of like, probably it. But I think in practice, in clinic, we see evolution for years and decades. And it may not be that that guy is going to go back and pick up his engineering. I feel like it was something really intense, but we're going to continue to see evolution of these people. And, you know, so I think the instilling of hope never ends. It's more like a pivot or a modification or a way of seeing it a little bit differently. So I try not to get stuck with patients anymore about, you know, it's been this long and I'm never going to get that back. We just kind of change the conversation a little bit.
So you reminded me, Beth, that there's two different kinds of patients who approach you several years after. There's those who've had active rehab, and there's those who've been sitting untreated for several years. So, you know, you can still see change 3 years afterwards for sure. But if they've never had a go at rehab, like the whole works, OT, PT, VOC, and cognitive, if they've never had it, it's possible that they are going to improve once they've learned some skills. And so it's not entirely right to just say, well, it's been 2 years and it's been, because if it's been 2 years where they're sitting at home watching television and playing on the computer or something, that may not be quite the same as being actively engaged in rehab.
Yeah, and if there's anything that I've learned from Dr. Barrett, who I'm not sure if she's on or not, but is that no matter what stage they are in their recovery, if they're not currently doing speech, occupational, physical therapy, and they're having some major impairments in their daily function, please refer, because that's going to be super helpful.
Thank you for the wonderful grand rounds talk. I feel like in clinic, I've seen a significant amount of patients who've suffered domestic abuse, and we're now treating them for depression, for anxiety, for dementia. Do you know that, like, whether when it comes to securing resources, are those types of injuries, especially when they are more remote like that, or happened over kind of a longer amount of time, if they're considered like, would people qualify to get additional resources for that type of brain injury?
Honestly, it depends on if there's evidence for it. For example, the Massachusetts program does ask for a clinician or a physician's kind of documentation. So it would have to be a process where they are willing to open up with their physician about potentially injuries that they've sustained from abuse, for example. So if they have some sort of documentation, to say that they sustained a traumatic brain injury, there shouldn't be like an exclusion for them to get into the programs. Yeah. Did that answer the question?
All right, there's a few more online here. Dr. Dan Breslin asks, what is the approach to a TBI patient with such dense anosognosia that they don't acknowledge any problems, even problems with living that are grossly obvious?
So I'm smiling because you just have to refer to Dr. Barrett then. So she is an expert in hemispatial neglect in general, not having that awareness of the deficit. And so she does actually offer therapies, one PRISM adaptation therapy or treatment, which may actually help. It really does depend on how close they are to the injury, but still, she's open to accepting those referrals and seeing if it helps at all. So that would be a really great outlet here that we have within our institution to go after. The difficult piece of this is if this person is living by themselves and unaware of their deficit. Sometimes you might not find it until you see them in clinic 4 or 5 years down the line. And so even then, it's still a good idea to refer, but it does sometimes delay that diagnosis of the impairment.
And there's one more here from Dr. Alex Ruska. Could we review predictors of good prognosis after TBI?
Absolutely, but that would be a completely different presentation. But yes. Unless there was a second part to that question.
Dr. Rothschild says we can learn from Dr. Barrett's work on how to approach our patients with anosognosia with schizophrenia and bipolar, which I think is really interesting as well.
Yeah, absolutely.